Hello, and welcome to the Alabama Public Health Training Network. Thank you for joining us for today's program, Health Teamwork, Chronic Disease Prevention and Management. If you have any questions about anything being discussed today, please call or email during our broadcast. The phone number and the email address are on your screen now and will appear again later in the program. Also, the handouts, sign-in sheet, and evaluation are all available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses and social workers for today's program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. While content may continue to be relevant, continuing education credits will only be awarded for 1 year for nurses, expiring November 30th, 2018, and 2 years for social workers, expiring on November 30th, 2019. Before we get started with the first presenter, let's define team-based care. Team-based care is defined by the National Academy of Medicine as the provision of health services to individuals, families, and/or their communities by at least 2 health providers who work collaboratively with patients and their caregivers. Team-based care can involve partnerships among various professionals connected internally and externally to a health system. This slide contains a list of potential professionals that can be involved in team-based care. Some of you may recognize certain professions from PPOD programs. Today, we'll be focusing mainly on the role of team-based care in diabetes prevention and management from the pharmacist to dietitian perspectives. Presently, about half of all U.S. adults have at least one chronic disease. 75 million, which is about 1 in 3 U.S. adults, have high blood pressure. 84 million have prediabetes, and 30.3 million have diabetes. Because of the fact that most of these individuals require medications, their visits to pharmacists provide an opportunity for an intervention in controlling their chronic condition. These interventions may provide an opportunity which will lead to the prevention of a hospitalization as well as improved outcomes. And now, let's meet our first presenter today. Dr. Anthony Bolus is the Clinical Coordinator at Family Medical Services Pharmacy. Dr. Bolus will be discussing the role of the pharmacist in team-based care and will provide an overview of diabetes prevention program that utilizes team-based care.
Hi, I'm Dr. Anthony Bolus, Clinical Pharmacist Coordinator for Family Medical Services Incorporated, where we have 3 independent pharmacies in 3 counties of Alabama. My job today is to tell you about the role of team-based care in the treatment of diabetes and looking most importantly on the pharmacist's role in that field. So let's go ahead and go into it here. When we talk about the pharmacist's role in team-based care, pharmacists are the medication experts. We have multiple years of education that makes us the experts in this field. We love to collaborate with our providers, but we can help providers understand, especially those physicians who prescribe, what medications truly go together and which ones don't. We are the adherence analyst. We solve reasons for non-adherence. There are multiple barriers on why patients do not take their medications. So I have a list of what ways we can help provide that for patients on the following slides here as follows. We also are the problem solvers. We find gaps in care, creating solutions to complex regimens. So let me show you a little bit about how we can do these type of things. First, we have MTM services. We have synchronization of medications, medication packaging, immunizations, DME services, compounding, delivery, wellness screenings, and also, most importantly here that we're talking about in terms of diabetes care, diabetes education and diabetes prevention classes. Let's talk about these a little bit more in detail. In terms of the MTM services, these are ways that we can educate patients on disease states and medications. These are called drug utilization reviews. Gaps in care are things that we can truly solve. And ways that we can communicate with providers are these SBAR notes. This is the situation, background, assessment, recommendations. This truly helps us to speed up the process on being able to identify a problem and have a resolution for a patient that's experiencing an issue. I have an example here of what an SBAR note actually looks like. This is what we use in our pharmacy. If we find something that's going wrong with the patient, we'll explain it as succinctly as possible for our physicians to be able to respond back to us in a timely fashion. Synchronization is another service that many pharmacies out there today are utilizing to help patients take their medications. And so what you'll be able to do here is simply take all the medications that a patient takes, have them fall on the same day each month. There is ways to do it. And insurance companies today are allowing it to happen as well. There used to be a lot of problems in the past where patients would say, well, I'm going to pay a $30 or a 30-day copay for a 5-day supply of medicine to try to sync them up. That's not necessarily the case anymore. So work with your insurance company, work with your pharmacist to know what codes that can be utilized in the field that pharmacists will submit the claim for that will allow insurance companies to help a patient only pay for 5 tablets for a 5-day supply of medicine. But this way will really help patients to be able to get all their medicine at the same time and not worry about a medicine having to be refilled this week or next week in 12 days, 14 days, everything all at the same time, once a month. And to help along with this, we have another system called the prescription packaging system. What this actually helps for is patients who may not be able to take care of the medicines on their own, or maybe this could be an option for caregivers in helping their parents or aunts, uncles, grandparents, or other loved ones that or even friends that can help them to take the medicines on a daily basis. What this does is that this takes away, I know a lot of the nursing homes out there have cups and stuff that they'll give to patients, but we can now utilize that format into residential life. So anybody can have this option where all their medicines are put into little dosage cups every day of the month. And again, these are calendar packs based on the time of day. So not only can we fill everything at the same time once a month, that's what the synchronization does, but we can also even package them into these calendar cards to truly help make taking medicines a whole lot more enjoyable and easier for our patients. We've seen tremendous progress in patients and their adherence rates when we switch them over to these packaging services, and these really do help patients, especially when you talk about adherence. You really do help them stay out of the hospital. And you can let them, instead of worrying about 2 hours or more trying to get all their medicines synced up, and sometimes they don't know if they've taken it or not, they might take double the dose. This can help family and loved ones know that everything is safe for their loved ones, even for themselves, give them a peace of mind, and gives them more quality time to spend with their loved ones instead of trying to worry about their medications. Everything can be done at the pharmacy now, and we really want to take that burden off of patients' shoulders. So just to give you some examples of what some of this looks like, we have a couple of systems out there. There are more out there, not just these, but these are some of the most common ones. But if you look at that, we have the medication sync of medications in there. And so we see this actually with a lot of patients. If you go into their homes, you might see old medications that they don't even need anymore, but they're just keeping them there. So we try to triage them. We even do home visits a lot of times out there. And some other pharmacists out there do that as well. But you can really help to take all those medicines and put them into these convenient cards. No more vials to have to worry about. And a lot of these cards are travel approved too, so you can go in the car or on the plane and not have to worry about being stopped for that. This is a little bit more in-depth look on some of these slides here. We have medicine on time as one of these options here. These are even perforated. You can take them out and put it with a breakfast or supper, any way that's convenient for them to take their medicines. Again, that example that we have here is a blue card, so that would be their nighttime medicine. A yellow might be morning, white would be noon. So different colors to represent the different times of the day to take the medicine. And the patients really do enjoy this. Here's another option here. Dispill is another program that's out there for you. It has everything really into, I guess, one whole weekly card that has different times of day on it. So then a patient would get 4 cards to take their medicine on a daily basis there and just take the column that represents with that day. So same format, just a little bit different on how that's done. And there are multiple other pharmacies out there that might even have their own system on how they implement these type of packaging services. Immunizations, another key on what pharmacists have been able to do now for the past decade or so, is truly helps patients to have more access to care with these immunizations. They don't have to necessarily have a prescription for a lot of these. You have standing orders with physicians that would allow a patient to come on in, walk in, and get a shot. right then and there. So we have flu season coming up here, so that's going to be very popular. You got pneumonia, shingles, Tdap, a whole lot more. The only one that pharmacists can't be recognized for to do is the yellow fever shot. So you definitely want to talk with your health department on that. But again, pharmacies can do this on-site or even go off-site to help a job location out there who may not necessarily be able to get to the pharmacy. They can help their employees by having them all stay in their building and have a pharmacy come in and actually give their shots to them. This really helps increase the access to care and helping patients prevent a lot of these illnesses. Durable medical equipment. So this is another option out there that's available to really help patients, I guess, decrease fall risk or help them in certain situations that otherwise would be needed, like in a hospital setting, but they can get these supplies in the pharmacy even. And now, I will say you have to be careful with these. Some insurance companies, some payers will not allow certain pharmacies or certain companies to be able to give them these supplies. So I would double check with your insurance providers to make sure that this is available. But diabetic shoes is another big one that pharmacies can get involved with in helping providers and their patients when it comes to taking care of their feet, giving them lightweight shoes that they can use to decrease blisters, decrease pain and inflammation in those areas. So it can help patients get out there and actually go out and do some exercise that can actually help them in their disease state. Compounding. I know there's been a lot in the news about compounding, and it's rather declined a lot for some pharmacies out there as stricter regulations have to be in place. And patient safety is our priority here. But there are specific medications that may not be commercially available for a loved one that needs it. And so a pharmacy can compound it in different formulations that are out there to make it specifically just for them. There will be new regulations coming out around 2019 that pharmacies will have to abide by, and that might decrease certain pharmacies' availability to do some compounding. But overall, compounding is still there, is still around. So we can utilize it and help patients get the ultimate care that they need in terms of these medications that may not be available otherwise. All right, so delivery. This is a basic service that can be a simple solution for some patients on helping with their adherence rates. Having a delivery driver, getting to the patient wherever they are, whether it's in their home or we even have facilities out there that can utilize a delivery service from a pharmacy that can help their patients stay adherent. This is a very common issue that's out there, and a lot of times patients may not be comfortable with telling you they have an issue with getting a ride to the pharmacy. So sometimes you might have to just throw some questions out there, some open-minded questions that can ask them about these issues. And really about 6 or 7 out of 10, you might have a patient that says, you know what, I never knew you had delivery. I would really love that. So again, a simple issue, a simple fix to help your patients stay adherent to their medications. A rather new service, maybe over the past 6 years or so that pharmacies have been able to get involved with are wellness screenings. And so this is for your state employees, local government employees that have kind of utilized this service to where, again, the health department does these, but again, pharmacy is now able to do them as well. And it's really just to help increase access, again, to be able to reach more patients out there. And so what you'll see here is that pharmacists will be able to get blood pressure, they'll do a finger stick and get some glucose or blood sugar readings, cholesterol levels. They'll check your total body composition, so your fat-free mass level, basic metabolic rate, so how many calories are you expending. Your BMI is an important level as well. So the state will have specific levels that they must reach, and if they're too high, then we have to refer them to a physician for extra follow-up. It's a great service that's out there for our patients now, and really hoping that this may actually be more commercially available in the future. But right now, the state is doing a great job with helping their patients to be much healthier out there. We have patients who may not even have a provider who come in and get their screening, and they're kind of trusting this once a year to see if there's something that's high that they need to get extra follow-up for. And we've had multiple patients come in, and they didn't even know that they might be pre-diabetic. And so we can go ahead and get them involved into a physician and get them the right care, get them the right lab tests that they can check to see if that patient truly is pre-diabetic or even diabetic. So it's not just those, but we have hypertension risk, even cholesterol risk levels. So it's a really great service that's out there, and I think something that truly is something of the future of our healthcare system. All right, so diabetes, big topic. Again, our state is one of the leading states in America with the most prevalence of diabetes. So pharmacists now being able to get out there and educate patients about it is truly crucial. So we can help physicians, helping diabetes educators, all of us together in helping this epidemic. So we can help educate on type 1 or type 2 diabetes. You have accreditations out there from the American Association of Diabetes Educators and the American Diabetes Association. Pharmacists can provide that 10 hours of initial training and usually 2 hours of follow-up each year thereafter. So it's a really unique service, a great service that can actually be reimbursed for pharmacists. So that is very important. That it's a service that can really help everybody win in the game on fighting diabetes. Also, here I want to kind of take some time to talk about how we can facilitate team-based care. And so, really, some of the, I guess you can kind of say this is common sense, but it is something that we need to re-educate each other, each field, each discipline of the healthcare team. We just got to have respect. You can sing that song, R-E-S-P-E-C-T. It's a great song. It's a great moment for us to all come together. We've got to have it. We can't look at each other as the enemy. We don't want to send them over here because we may not get any benefit from it. If we truly look at just taking care of our patients, the payment can come with it later. But we've got to concentrate on making sure we take care of these patients, especially with our new healthcare system that's moving to more value-based payment models. And so we have to look at quality, not volume. We've got to look at quality to be able to determine if we're going to be able to help that patient and us survive in this new healthcare system. So again, we're all on the same team going after the same goal. So let's treat each other that way. One way we can do that, though, is through communication. All right, face-to-face. It's still a great practice, just going in and meeting that person that you might work with. As for a pharmacist, going to a physician's office, saying hello. I know it's busy. Times are busy. You might have to get there early in the morning, work out a time at lunch. But it's really important to recognize each other's faces and network that way. Also by phone is a great service, and electronic. So we're trying to get also high tech in the new environment. And so if we can utilize all three of these, we want to make everything transparent. And so we'll talk about ways that we need to try to have EMR integration. I think that's the wave of the future, where you're going to have us communicating, pharmacists, physicians, educators, social workers, hospitals, nurses, everybody being able to see an electronic document that goes with that patient wherever they may be. And this can really help to decrease preventable readmissions back to the hospital. A lot of times we see that a physician didn't know that something was discontinued, or a pharmacy may not know that something was discontinued. And you might have that automatic refill system, and it accidentally gets in the patient's bag, and they think they need to continue to take it, and then you've got problems. So being able to be transparent with each other is going to be very important with the new electronic medical record system. And again, just don't be afraid to ask. Just do it. That's going to be the simple thing there. Just talk about it with each other. One example that I have here, and I have some other examples further on in our slides, but even transitions of care. This has been a big topic of the healthcare system. More and more hospitals going to these type of models, being able to make sure a patient understands what their new regimen is out of a hospital and getting them back into the community setting. And so again, pharmacists are right there on the front lines being able to help with that. And so what's important here is that we can try to get a discharge summary from the hospital. And there are multiple groups out there, quality metric groups that are out there even right now that are working on models of care to utilize this more effectively. There are hospitals, too, that are doing this within their own health systems. But again, this is so important just to get that discharge summary of what a patient should continue, what should they stop, what should they add to their current regimen. And when a pharmacist sees them back into the pharmacy, we can see how they're doing, meet with them, and help encourage them to go get their appointment back with the physician. So again, that's going to be working together, back from the hospital to the pharmacy to the physician, to make sure that they're truly being cared for the new disease state that they might have or the condition that they're trying to get over from the hospital. So let's talk about a really hot topic now, the diabetes prevention program, something that can be utilized in a lot of things that we've already talked about. So the diabetes prevention program is an evidence-based research model that was done back in 2002, and it was researched over for about 10 years. So this is a way that they developed on how we can solve this iceberg mentality of where diabetes is. If you ever look at an iceberg, you might see a little tip of it above the water of the ocean, but down the bottom it's very large ice down at the bottom there. So that's kind of where we're looking at. We got about 86 million or 84 million pre-diabetics out there right now, and that's kind of the bottom of that iceberg. And so right now we're kind of at the tip of the iceberg, just barely seeing those who are already diabetic. And so that's why our federal government and a lot of health systems out there are trying to fight this epidemic of diabetes and helping to prevent or delay the onset of diabetes as much as possible. And so what this program was able to showcase is just lifestyle interventions, healthy eating and exercise, decreasing some weight, was able to do that in a very large format. And I'll just kind of show you the statistics here. In that patients who are at risk, actually with healthy eating and exercise, and their magic number here was a 7% reduction, but they saw it between 5 and 7% reduction of their weight, actually decreased their risk or delayed the onset of diabetes by 58%. For those who are 60 years and above, 71% effective. Just lifestyle maintenance here. And they even tried this with metformin, which is a very common medication, usually first-line therapy for a lot of patients who are diabetic, even pre-diabetic, they might have this agent. But that was only 31% effective. And so you saw a huge advantage here on just exercising or telling patients about healthy eating and exercise. So one way that they were able to triage patients for this, well, one is a blood test. That's very important. There are ranges there from the American Diabetes Association that can specifically showcase a patient to be at a pre-diabetic range, which again is not necessarily high enough to be diabetic, but it's not normal either. This is a screening test that can be performed. It's a multiple question list that can be found on the CDC website, so you're welcome to look that up. Just listed out all the questions there for you, and there's a scale. And if a patient, there's a legend online, if you go to that website, there's a legend on there they can actually specifically see on if it's a score of a 9 or above, that patient is at risk for diabetes. So again, I just go to cdc.gov. You can also just type in or Google DPP, National DPP Program, CDC screening check, and you're going to see it come up for you. I wanted to at least showcase to you a little bit of the core curriculum that's involved on this. So again, when individuals, really healthcare systems, and I'll tell you that here, and I'm even including saying pharmacies or even being like a healthcare facility, all of these institutions can actually register to be a DPP provider. And within that, you have to become a lifestyle coach. And there's training for that, the specific regulations. Again, the DPP website from the CDC can actually specifically show you how to do that. But the curriculum that's involved is pretty straightforward, and it's given to you. You kind of have to abide by the curriculum. Again, this was used in the study. There are different types of curriculum, but this is one of them that I've chosen to kind of show you what each topic will talk about. But the first core, again, it's divided into two sections. The first core is 16 weekly classes where all these topics here that you see are involved. You know, you talk about healthy eating at the beginning. You talk about exercise. There's even coping exercises or classes that are involved in the end, stress management. All of these things are talked about within the first 16 weeks. And I put on there 16 weekly classes performed in 24 weeks. They kind of give you a little bit of a breathing room just in case you have holidays you have to work with. You might not be able to meet every week. But within that 24 weeks, these 16 classes must be kept. So great information here for our patients to be able to understand and take to heart. Most of these classes are going to be about an hour long, so it shouldn't be very time-consuming. But you can perform them not only in a clinic, but you can perform them anywhere besides a residence. You just can't do it at a patient's house or your own house. But you can do this anywhere. And this is something that even Medicare is going to start paying for providers to do next here in 2018, which we'll talk about in just a little bit. But after the first core session, again, those are your core weekly classes. That's the first part of it. That goes through 6 months. You then go into this post-core curriculum. Now this, we kind of start to take the training wheels off of our patients, and so we're not going to be as hands-on with them anymore. Again, when you're in those 16 weekly course sessions, you're getting their weight, you're getting their waist or their weight measured once a week. You're just keeping them accountable. And so that is very important on helping them reach their success. You're also having them track the food that they take every week. And you're grading that. They might have a little bit of homework where they just kind of reflect on what they've learned over the past week. You can have incentives on there for them. If you're doing Medicare payment, you have to kind of watch on some of those incentives. But right now, when you're talking about getting CDC recognition for it, there are multiple ways that you can help patients to be able to reach their goals. And again, that 5% mark is really the big goal that we're all trying to help our patients reach, that has been statistically proven to help decrease their chance of diabetes. So this post-core curriculum, again, taking off those training wheels, we're now, instead of meeting every week, we're going into monthly sessions, once a month, about 6 sessions to last you for the end of that 6-month routine. So these are multiple topics that could be involved for those patients within those 6 months. And the coach would be able to pick which one of those that he thinks or she thinks would be beneficial for them. All of these right here, again, that you're seeing are even more topics that are available for you. All right, so real quick here, I wanted to kind of talk to you about the economic cost of diabetes. Again, in 2012, the total cost of it was about $245 billion. So again, our healthcare system is just getting overwhelmed with these, and again, this is just with those 20 million patients, 29 million patients who have diabetes right now, and we have 86 or 84 million right now that are pre-diabetic, and so these numbers are just going to exponentially increase over the next 20 years. And so that's why we've got to act now. People diagnosed with diabetes incur that 2.3 times more medical expense, and a lot of this can just be from complications of the disease. All right. So again, most of that is why the DPP program has come around, and it is cost effective. If you even see here, and I haven't mentioned it earlier, but I have it on this slide for you to also notice, they even did a 10-year follow-up from the study. And again, the study was very unique in that it had multiple backgrounds of patients who were studied on this, every male, female, races. And there was a very good study here that showcased this change, which is why it's actually being put into practice now. But even 10 years after the study, 34% of them still remained non-diabetic, which I think is very important there. But again, when we talk about diabetes, sometimes there are genetics involved that might be troublesome for some patients being able to develop later down the road. But most of all, this program can still help decrease patients' risk of diabetes. The cost to prevent diabetes, again, and you can see it from the slides here, is much less than what actually having diabetes is. And so that is why this is starting to be put into practice for Medicare to even start paying for these type of classes for those who qualify. And so again, here you have some qualifications. If you're looking at this as a provider or a facility and you're trying to figure out what should I do. Now again, these are proposed. It's still a proposed model, what all is needed. So I need to make sure there's an asterisk there on some of these. But most of this is probably going to go through as we go into September and October when they finalize these rules. But you must have an NPI number, even for non-physicians. You've got to have that CDC official recognition to get all the payment from Medicare. But there is a preliminary status that will be involved that providers can actually obtain to still run the classes, get paid for them, but you're still not going to get paid the maximum amount. And usually that's a 1-year amount of data that you must have to showcase to the CDC and Medicare. Now, when we get into this slide, and I know it's kind of a busy slide, and you can look this up again with the DPP, and I got this off the American Medical Association. But it shows the newest proposed, again, I have to put that asterisk on there, proposed model on what the payment structure is going to look like. And so you'll kind of see right there, you'll get payments for attendance, but then you're also going to get a maximum benefit there for actually succeeding in getting a patient to achieve that 5% weight loss goal. Again, this is brand new stuff where you're actually having a payment structure on value-based care, and it's not just volume here. So that's very important. Now, down there you see 810, and you're probably like, whoa, you know, that doesn't add up to 810 if you just look at all those numbers right there. Well, on that very last column, right above that $810 mark, you'll see that 3-month intervals. So you have a maximum of 8 3-month intervals that you could get paid that $50 for. And so that will actually add up to $810 there. But again, if a patient does not achieve the 5%, then providers will only get paid the attendance rate, which would be that 125 mark. So it's not all for nothing for them, and hopefully the patients will have it sink in for them later down the road. Again, this is going to motivate all of our providers to talk to each other. You know, the DPP program is going to have patients lose some weight. And when they lose weight, they're going to have to need their medications to be changed. And so, again, this is really going to be a great essence to help our providers, to help all of our disciplines work together on helping a patient accomplish a goal, and to help our goal as well on making sure we keep patients healthy and safe and living the good life as much as possible. So, again, communication here is going to be essential for them and for us. Data reporting is going to be occurring, and so this is very important. For payers, we need to track our data and our outcomes, and working together to showcase our essence and our true work ethic to be able to be reimbursed for a lot of these new collaborative models of care. And so when we talk about collaborating together in multiple disciplines, the one other person part of the team is the patient. So patient-centered care is the future, and a lot of practice sites are probably doing it now, but essentially we've got to include the patient in there with us, working together to accomplish that goal like we talked about at the beginning. So in summary, I know we talked about a lot of information today. I hope you'll learn something, but in summary here, pharmacists can help in many ways beyond filling prescriptions. Having respect and earning respect for all disciplines of the healthcare team is essential. The DPP program, Diabetes Prevention Program, is a new lifestyle change program to help delay or prevent the onset of diabetes. And then the DPP here fits the agenda of team-based care and optimizing outcomes for patients using the different strengths of the healthcare team. All of this information here is available for you. I hope you've learned something from it. You can always contact me if you have any questions whatsoever. Good luck to you. If you're a patient listening out there, reach out to your physicians, your providers. If you are a provider out there, talk to the different disciplines out there, and let's work together on helping to solve this epidemic of diabetes and helping patients live the good life. Thank you so much.
Thanks, Dr. Bolus, for that summary of team-based care and the pharmacist perspective. Dr. Bolus made some great points that communication is essential and respect for other health professionals is important to team-based care. He also highlighted early in his presentation another diabetes program that helps facilitate team-based diabetes self-management education, or DSME. DSME is the ongoing process of facilitating the knowledge, skill, and ability necessary for diabetes self-care. This process incorporates the needs, goals, and life experiences of the person with diabetes and is guided by evidence-based standards. Our next speaker, Amy Harden, is a registered dietitian at East Alabama Medical Center. She'll discuss DSME and how the registered dietitian and the medical nutrition therapy can play an important part in team-based care for diabetes.
Hello, my name is Amy Harden. I'm a dietitian and certified diabetes educator at East Alabama Medical Center, where I'm the Director of Diabetes and Clinical Nutrition. Today, we're going to be discussing the benefits of team-based care in the management of diabetes, and I'll be sharing with you the experiences of our center in using a team-based approach. Our objectives for today will be to discuss what diabetes self-management education is, to describe the integration of medical nutrition therapy within a diabetes self-management education program, and to identify the benefits of a team-based approach to diabetes care. So why do we need to discuss diabetes education? Well, as most of us know, Alabama ranks first in cases of diabetes based on the 2015 CDC guidelines. Approximately 13% of the population in Alabama has diabetes, and this is compared to a 9.3% of the U.S. population. And diabetes accounts for 25% of deaths in the state of Alabama. Now, nationally, the financial impact of diabetes is staggering. with direct cost related to diabetes of $176 billion and indirect cost of $69 billion. The direct cost of diabetes are related to the complications such as heart disease, stroke, retinopathy, nephropathy leading to dialysis, and neuropathy. Direct costs also include the cost of medications, physician visits, hospitalizations, and emergency room visits. The indirect cost of diabetes are related to absenteeism and reduced productivity due to the complications experienced by people with diabetes. Now let's talk about the effectiveness of diabetes self-management education. So we have established that diabetes has significant health and financial implications. The Diabetes Complication and Control Trial and the United Kingdom Prospective Diabetes Study showed that reducing A1C can significantly reduce the complications of diabetes, which therefore can reduce the cost of diabetes. Because of these two landmark studies, A1C, which is a reflection of blood glucose control over the past 3 months, has become the gold standard used to determine how well a patient's diabetes is controlled. And so this is often a standard used in studies to look at the effectiveness of diabetes interventions such as education or medication therapy. The A1C guidelines from the American Diabetes Association are that most patients with diabetes reach a goal A1C of less than 7%. So again, as I stated, this A1C can be used as a way for us to look at the effectiveness of treatment. So what we have here is a systematic review of diabetes self-management education. This was done in 2016 by Shervala and colleagues. And they looked at the effectiveness of diabetes self-management education. And in the studies that they looked at, the studies included individual training, group training, or a combination of both types of training, including individual and group. And what they showed in their study, well, let's back up a minute here and look. And these studies were all heterogeneous in their mode of delivery. Some of them were in person, some were telehealth. Providers, there were dietitians, nurses, physicians, pharmacists, exercise physiologists. Duration, anywhere from 1 visit up to 2 years. The contact hours, anywhere from 1 hour to greater than 10 hours. And the frequency of follow-up. And there were 118 unique interventions that they looked at. And what they concluded is that the patients receiving the interventions of diabetes self-management education saw a 0.74% reduction in A1C. And in the patients within the control groups, which meant they did not receive any sort of intervention, there was a reduction of 0.17%. And so we can see from this that there is definitely a significant difference in patients receiving some sort of intervention. Further stratification performed by this group showed that a combination of group and individual education resulted in a 0.88% reduction in A1C. And the education provided by a multidisciplinary team resulted in A1C reductions 69.6% of the time versus 56.3% of the time when provided by a sole provider. And that solo provider, again, could have been a dietitian, nurse, pharmacist, physician. So what we see here, once again, is that diabetes self-management education can be effective. And as we discussed earlier, those reductions in A1C can lead to decreased complications. So taking this systematic review, we wanted to look at what happens in our own state in a diabetes center in an actual clinic setting. So what we looked at was the Diabetes and Nutrition Center program at East Alabama Medical Center. And we did a retrospective chart review. And we'll discuss the details of the center and the team-based approach here in a few minutes. But we'll look at the results of this study again just to show us how effective a team-based approach can be. This program is multidisciplinary and provides individual and group education. So what you can see is on the last line here of the study, looking at the A1C reductions, we can see that there was a mean baseline of 8.74% of patients participating in the program. At the end of the program, the mean A1C was 6.82%. You can see this is a significant reduction, and as we've already stated, reductions in A1C can decrease complications. If you'll also remember, we talked about the importance of the A1C reaching less than 7% as the goal set by the American Diabetes Association. So you see here we did have a significant drop in A1C. We also further queried physicians to ask them to provide information on patients at 1 year out after their initial visit. And at that time, even though the A1C had risen slightly to 6.9%, it still remained a significant decrease and also below the 7%. If we look at BMI and weight, we will also see reductions here. You can see the baseline BMI and weight here on the chart, and you'll see post-MNT, which is the end of the program, we showed a significant decrease in both of those within the weight and BMI groups. You will see that at the 1 year mark, those numbers had risen, so they lost their significance, but they were still below the baseline. So what this helps us to see is that we have literature out there to support a team-based care from intervention studies with randomized control trials, and bringing it further to our own state, we can see that in our diabetes centers across the state that we can achieve even greater reductions of A1C. So now what I want to share with you is how the program at East Alabama Medical Center is set up for a team-based approach. This is just one way that you can implement diabetes self-management education and MNT within your setting. But we wanted to share some of our ideas with you in hopes that you can help in your areas, in your centers, to establish a team-based approach. So you'll see we start out with an individual assessment of our patients. When they come in, they are seen for 1 hour, either by the nurse or dietitian who is part of our team. And during this assessment, we measure height, weight, BMI, blood pressure, and a point of care A1C test within the clinic if one has not been done within the previous month. During this time with the patients, we are able to talk about their current medication usage, their past medical history, family history, and social history. During this time, we'll also teach them how to self-monitor blood glucose. We can also review any appropriate timing of medications, especially insulin, during this time. After this initial assessment is done, patients are set up into a group training session. We'll talk about the contents of that in just a few minutes. But the group training sessions are set up as 3 2.5-hour sessions within 1 month of the assessment visit. And during these times, these are performed by the dietitian, the nurse, the pharmacist, and the behavioral health specialist. And then 5 months after the completion of the class, the patients are brought back in for a 1.5-hour session that is performed by the dietitian and nurse in conjunction in the class. And during this time, the patients are able to discuss their successes, their barriers, and we also help them to set up a diabetes self-management support plan. So let's talk about the 10 content areas that are covered during a diabetes self-management session. And these content areas are laid out to us from the National Standards for Diabetes Education and Support. And you'll see we discuss pathophysiology, monitoring, nutrition, medications, physical activity, acute complications, chronic complications, psychosocial adjustment, goal setting, and then preconception and pregnancy management is discussed either in individual sessions with the nurse or dietitian. So let's talk about how this team-based approach is so important when we're discussing all these different content areas of diabetes self-management education. In our center, what we use is a curriculum called Conversation Maps by Healthy Interactions. And for those of you that are not familiar with this curriculum, the educator actually works as a facilitator to guide the patients through different topics as they are outlined here. And the goal is to have the patients actively participating in the discussions rather than a lecture-style approach. So our class series begins with the behavioral health specialist. Most of us in diabetes education are well aware that diabetes is definitely a disease that requires a lot of self-management by the patient. So we have found that it's a great help to the patients for them to be taught about psychosocial adjustment, behavior change, and goal setting at the very beginning of their class sessions. This helps the patients to know that the information that they are going to be gaining in these sessions, what they need to be focused on, what they can look at, and it helps them to start thinking about how they want to engage in these activities. And again, using the team-based approach by having a behavioral health specialist specifically trained in these ideas, they're able to get the class setting started off by getting the patients to interact and to go ahead and be able to alleviate their fears of what to expect in a class, and also to be able to talk about how they feel about this diagnosis of diabetes. We started using this approach 2 to 3 years ago and have found that it can be very successful in helping our patients reach these self-management goals. After the behavioral health session, the nurse comes in to teach the pathophysiology, the monitoring of self-blood glucose monitoring, monitoring A1C, and the acute complications. And then the pharmacist or nurse comes in and teaches about the medications that the patients are on. They're able to address questions about diabetes-specific medications, timing of medications, storage of insulin and non-insulin injectables, and they're also able to have a discussion with patients who may be concerned about interactions with other drugs. Again, we've recently been able to add this pharmacist to our team and realize the benefit that it helps the patient and not only and helps us as well. The dietitian trained in diabetes self-management education then comes in and provides the basic nutrition education for the class. And in this time period, they're able to talk about basic concepts of nutrition and basic carb counting. And then in our last class, the dietitian or RD will talk about the ongoing care of diabetes and what they need to do. They'll talk about exercise, chronic complications, and standards of care. And these standards of care include such things as how often should you have an A1C done, when should you get your blood pressure checked, foot care, eye exams, and various other standards of care. Once the patients attend all of these sessions for the diabetes self-management education, they're able to go home and begin using these skills. And then it's at this point that we have integrated the medical nutrition therapy portion for the diabetes self-management classes. 1 to 2 weeks after the class completion, patients are scheduled to come in for a visit with the dietitian. This visit normally lasts for about an hour, and it's at this time that we can really individualize the patient's diabetes plan of care. During this visit, which is again by the dietitian who is trained in the care of patients with diabetes, they provide patients with the individual sessions discussed in class. The patient and the dietitian work together to discuss the successes the patient has had, and then they can discuss the different barriers to eating healthy, self-monitoring, and exercise. Patients at this time bring in blood glucose diaries and food diaries, and they sit down with the patient, and the patient's able to use the skills they learned from the behavioral health specialist to talk to the dietitian about problem solving. It's also at this time that we're able to continue that teaching with the patient to discuss healthy fats, eating out, and the individual needs with patients, such as vegetarianism, a renal diet. If there's any gastrointestinal issues, the dietitian can discuss this at this time. During these appointments with the dietitian, one of the benefits of the team-based approach is that you still have the nurse, the pharmacist, and the behavioral health specialist. So at any time during these appointments that other issues may arise, we're able to pull the other team member in order to help us with the further needs of the patient. 3 months after the initial assessment, the patients come back in for a second visit with the dietitian. During this time, they're also looking at their weight, their BMI, and doing another point-of-care A1C testing. And again, at this time, they're talking about successes, barriers, looking at medication usage, and all throughout all of these visits, there's a continual feedback to the physician with how the patient is doing with their goal setting, what their blood sugars look like, their weight loss, and making medication recommendations back and forth between the physician and the team at the Diabetes Center. After this last MNT visit is where the patients come back for that last group training, as I discussed earlier. And just to point out there, as we discuss diabetes self-management education and MNT, with diabetes self-management, it is definitely an ongoing process of facilitating the knowledge, skill, and ability necessary for diabetes self-care. And during this last time that we have with the patients before they are discharged from our program, they're able to reflect back on the group sessions they had, the individual sessions, and they are able to discuss these things with the nurse and the dietitian as they continue to further their journey of taking care of their diabetes. During this time, we focus on the AADE7, which looks at nutrition, physical activity, medication management, problem solving, and this is a very patient-led class that we have in the end for us to be able to, the patients are ready to go out and take care of themselves on their own, and also to develop a diabetes self-management plan. If we find during this time that the patients still may have some needs that need to be addressed by the behavioral health specialist or by the pharmacist, then we're able to set up another individual session after this meeting in order to allow them to do that. So just reviewing again what medical nutrition therapy can offer along with the diabetes self-management education is it can offer nutrition diagnosis and therapy and counseling. It's individualized, provided by the registered dietitian who has the additional training to help patients with their diabetes, whether it be type 2 or type 1. In type 2 diabetes, it may be basic carb counting. In type 1 diabetes, patients may need more advanced carb counting skills to include using a multiple daily insulin injection regimen or insulin pump therapy. So in conclusion, as we've shown in the systematic review and the retrospective chart review, a team-based approach is an effective way to provide diabetes self-management education and medical nutrition therapy resulting in A1C reductions. The approach that we have used is just one approach to team-based care. Based on facilities that you may have and availability of other disciplines, you can develop a team-based approach that works in your specific area with your demographic. Other disciplines to be integrated into team-based care may include exercise physiologists and podiatrists, and of course we always have our physicians and nurse practitioners who are referring our patients to us that we are working with that are part of our team. So again, the multiple disciplines that we have are the dietitian, nurse, pharmacist, and behavioral health. And as we've discussed, they all bring their area of expertise into diabetes self-management education and medical nutrition therapy. Not only does this help the patients, but it helps the staff within our center to have a continued learning from all of these different areas who have their own expertise. Motivational interviewing and goal setting is used by all members of our staff as we're all trained in this, but trained in a little different way. So once again, this helps us to make sure we get the right patient with the right discipline in order for them to be successful with what they need to do. So I want to thank you for your time today. And if you have any questions or comments, feel free to reach out to me at amyhardin@eamc.org. That's AMIE.HARDIN@eamc.org. And good luck in your endeavors as we all continue to make a difference in the lives of our patients with diabetes. Thank you.
Thanks, Amy, for your review of DSME and the registered dietitian's role in DSME and team-based care. Diabetes affects several systems in the body. If you have type 2 diabetes, you are at greater risk of heart attack, stroke, and death from cardiovascular disease. It's important to know the facts about diabetes in order to cut your risk of complications. Our final presenter today is Keisha Nelson from the YMCA of Greater Birmingham. She'll give an overview of a blood pressure monitoring program in the community setting that highlights how the community plays an important part in team-based care and the management of chronic diseases.
Hello, my name is Keisha Nelson. I am with the Birmingham YMCA, and I am here to talk to you about the YMCA's blood pressure self-monitoring program. So a little background about our program is that in an effort to address high blood pressure, the Y has designed an evidence-based self-monitoring program aimed to help participants better manage their blood pressure. The program emphasizes self-monitoring and tracking of individuals' pressure so that they can play a significant role in reducing their pressure and improving their quality of life. The program, a little background about the program is it's a 4-month evidence-based program. In the program, participants receive a blood pressure monitor. We give them materials to help track their blood pressure. We also provide 4 nutrition seminars throughout the program, and each participant receives 16 weeks of access to the YMCA. So the program is completely free at the Birmingham YMCA, and we have 4 sites that conduct the program, but our participants are allowed to utilize any of our facilities throughout the duration of the program as long as they are attending the seminars and turning in their trackers for self-monitoring. So, as we know, about half of the United States adults have at least one chronic disease. The medical care accounts for 84% of the U.S. health expenditures. 7 of the top 10 causes of death, chronic disease, is heart disease is the number 1. And about 1 in 3 United States adults have, so it's about 68 million, have high blood pressure. So this is why we developed the program in an effort to try and lower blood pressure, which in turn lowers heart disease, diabetes, obesity, stroke, and chronic diseases of that nature. So healthy living, improving the nation's health and well-being. Critical social issues affecting our communities. High rates of chronic disease and obesity in children and adults. We know Birmingham ranks really high, and in an effort, the YMCA wanted to create a program to where we not only did self-monitoring with their pressure, but we addressed physical activity by giving them the 16 weeks while they're in the program to give them the access to the YMCA that they may or may not have if they weren't in the program. We do address, we have 18 and older in the program so that if they're 18, they can join the program, but we do have older adults in the program as well. Our shared intent. We want to improve the lifestyle and health outcomes in the U.S. The Y will help lead the transformation of health and healthcare from a system largely focused on treatment of illnesses to collaborative community approaches that evaluates well-being, prevention, and health maintenance. Our desired outcomes are for people to achieve their health and well-being goals, to reduce the common risk factors associated with chronic disease, and the healthy choice is the easy, accessible, and affordable choice. So the way we addressed it to be affordable is we made the program free. So as long as you have high blood pressure, you're eligible for the program, and there's no charge to the person at all. We don't charge for the machine, we don't charge for the 16 weeks access for the YMCA, and we don't charge for the Healthy Heart Ambassador that they receive during the program. And then we also emphasize prevention for all people, whether they are healthy, at risk, or reclaiming their health. And then the whys, we try to partner with key stakeholders within our community to help us to promote the program and to help us to continue the program throughout the year. So, the why's unique role. The vast majority of factors affecting our health are outside of the healthcare system. The whys have the right to support people in the day-to-day work of preventing and managing chronic disease. And the combination of local presence backed by the national network makes the why unique, credible, and powerful, and we have a lot to give. So not only do we have our self-monitoring program, but we also look at the participants in the program and see if they could qualify for any of our other programs like diabetes prevention or Live Strong, which is our cancer survivors program. And then we also have a program where we go out into the community and teach group exercise classes for free. So most of our participants who are in the blood pressure management program do qualify for those programs, and so that allows us to filter them through other programs, as well as if they just want to join the Y for health and wellness reasons, we do have scholarships available for them once they complete the program. So the Y's National Million Hearts Commitment. The initiative launched by the Healthy Heart Association, by the Y, the Million Hearts, brings together communities, health systems, nonprofit organizations, federal agencies, and private sector partners from across the country to fight heart disease and stroke. Our goal is to prevent 1 million heart attacks and strokes by 2017. The Y joins the CDC, HHS, and CMS in Million Hearts Initiative. So in Chicago, September 2011, the Y announced its support of the Million Hearts Initiatives, an initiative spearheaded by the U.S. Department of Health and Human Services, Centers for Disease Control and Prevention, and Centers for Medicare and Medicaid Services that aim to prevent 1 million heart attacks and strokes over the next 5 years. Health equity, intentional engagement in underserved communities. So the way we have addressed this is we have strategically placed the program in certain YMCAs throughout Birmingham. But as I said earlier, just because you can sign up at those locations doesn't mean that you can't use our other locations. We also go into community centers, churches, schools, and other organizations to where we sign people up for the program so that they have access. So it may not be that you want to come into a Y. Some people are intimidated by YMCAs, so we try to take the program to the community so that everyone has access to the program. In the condition in which everyone has the opportunity to attain their full health potential, and no one is disadvantaged from achieving this potential because of their social position or other socially determined circumstances, is a definition of health equity, and we feel like we have addressed that by taking the program to the communities. Doing our part requires approaching communities with respect, building trust, developing strategic partnerships, gaining understanding of diversity and cultural competence, and navigating around barriers to ensure needed services are truly accessible. So what we found is groups work better together. So if there's a church, we approach the pastor. The pastor says, yes, you know, he invites us in, and then they work together. And by that, they have a partner, and they usually commit to the program a little longer and stay in the program. Because our goal is if they sign up, we don't want them to sign up for a couple of weeks, get discouraged, and not continue. We want them to continue through the 16 weeks, and then from there continue with the YMCA so that they can continue to lower their blood pressure and eventually not have to be on medication. So, the blood pressure self-monitoring program. So as we know, high blood pressure is the silent killer. Most people do not know they have high blood pressure is what we found, and most people either feel like they're okay or they don't want to take the medication. They may not have insurance, or they may not have access to be able to do what they need to see a physician to get what they need to lower their blood pressure. So heart disease and stroke are two of the leading causes of death in the United States, and the program addresses both of those. So the overview of the program, as I said, it's a 4-month evidence-based program designed to help people with high blood pressure better manage their blood pressure by developing the habit of monitoring. So when we provide them with the machine, we show them how to utilize the machine. We give them a tool to track, and each time that they come in for their visit with their Healthy Heart Ambassador, they give us that card that's tracking their pressure so that we can monitor it through our system, which is called RedCap. Once we put that in, we look at how their pressure either is maintaining or if their pressure is lowering over the time that they're in the program for the 4 months. We also require them to attend the nutrition seminars. We have 4 nutrition seminars, which we have once a month during the 4-month program. And then we collect all of that data so that we can look at the evidence from when they first started the program to when the program ends. So who qualifies for the program? Adults with high blood pressure or hypertensive or on hypertensive medication. If they are interested in self-monitoring, which means they have to commit to be able to monitor their blood pressure on a daily basis, and they must not have any recent cardiac events, no atrial fibrillation or arrhythmias, and no risk of lymphedema. What is the program? It's a 4-month program supporting participants in developing the habit of self-monitoring and identifying opportunities for action through weekly support and 10-minute consultations. We try to make the consultations as quick as possible because we understand that people have busy schedules and we don't want to hold them there for a long period of time to discourage them from coming back again. And the nutrition and physical activity information to aid in blood pressure control through lifestyle change. So we have 4 sessions that they will attend throughout the 16 weeks. And in those sessions, they last about 30 to 45 minutes in which we give them information on how to shop, how to eat when they go out, how to lower their salt intake. And when and where. So it's anytime, anywhere. Like I said, we do programs in churches, we have programs in schools, we've done neighborhood associations, we'll go out to a company or a business and do it on a lunch hour where we can do lunch and learns, and we also have programs within our YMCAs. As long as we have the space for the blood pressure stations and the nutrition education seminars, and then we have adequate privacy so that we do not have anyone where we're speaking out in public, so we try to keep everything private. And like I said, we have many non-YMCA sites, workplaces, clinics, community centers. So how? We do training on proper blood pressure management techniques, and we have ongoing support, education, and coaching from trained staff, tools for self-monitoring and tracking, and we send weekly messages. We have drop-in consultations and seminars. So we try to send out a weekly email or a phone call to those participants so that they know that we're here if they need us, if they need to change an appointment, if they feel like something's going wrong with their pressure. And then we also have partners with doctors, so if we need to refer someone to a doctor, or if we need, to bring someone in, or if we see that someone's pressure is not going down over a period of time, we can refer them to that doctor so that they can get additional medical help. So the program has really worked for us. We've seen that at least 15% of our participants on the program have lowered their pressure, and we do have about 4% that have come off of medications altogether. With the program, the utilization of the Y we feel is key to the program because it also gives them that physical activity, but it also lets them know about the other programs that the Y has to get them engaged in health and wellness overall. We do about 6 sessions a year with the program, and each session they overlap a little bit, but they last for the 16 weeks, the 4 months, and then participants are allowed not to do consecutive sessions, but they are allowed to take a session, take a break, or if they want to join, and then they can do another session. So the program is totally free, and we feel that it has been a real asset to our community. Thank you. My contact information is knelson@ymcabham.org if you have any further questions or concerns, or if you would like to see about expanding the program.
Thank you, Keisha. If you have diabetes, learn to manage it well. By learning to work with your team of healthcare professionals, it gives you an edge, the edge you need to prevent complications, live well with the disease, and afford the opportunity for a better quality of life. And now, if you have any questions about team-based care and chronic disease management, you can call or email us. The contact information is on your screen now, and we have members of the cardiovascular, diabetes, and nutrition staff from ADPH that will be glad to answer any questions you have. While we wait for their questions, let's turn to Lita Chatham to explain to us how proper nutrition can help you manage your diabetes. Lita?
Thanks, Ashley. Well, as we just talked about, nutrition is a very integral part for diabetes self-management. Eating a balanced diet and making intentional carbohydrate choices are very important for maintaining blood glucose levels and improving your HbA1c. A good rule of thumb for individuals with diabetes is to fill half your plate with the non-starchy vegetables and then add in your carbohydrate and lean protein choices. And you do want to have protein at each meal and snack to help maintain steady blood glucose levels and avoid highs and lows. Reading the nutrition facts label is also important for making informed food choices. And for healthcare providers, it's important, as we just learned, to include registered dietitians in the care of patients with diabetes. And also making those outpatient referrals for patients with diabetes, especially those newly diagnosed with diabetes, to outpatient counseling centers where they can receive the nutrition counseling, support, and education that they need to manage their diabetes and to also help avoid unnecessary hospital readmissions.
Talk about lean proteins and the starches. Could you kind of give us a few examples of those? I mean, some folks may know, some may not. Just kind of give us some examples of vegetables that are starchy and then lean proteins.
Sure. So starchy vegetables are going to be things like your potatoes. They're going to be things like your French fries, which are also potatoes. They're going to be things like corn, peas, your beans, and some beans and legumes are going to be considered starchy vegetables. And then your lean protein choices, we talk about protein. In the South, we do a lot of fried chicken and fried pork chops and things like that, and those would not be considered lean choices. You want to stick to more your chicken, baked, broiled, or grilled without the skin, or your turkey, or your even beans and peas can be healthy protein choices. So, your poultry, fish, things without the skin, things that aren't deep fried, that are, as I said, grilled, baked, or broiled, those are going to be better protein choices and are going to help maintain your blood glucose level and also be heart healthy choices.
All right. And if you have any questions, please feel free to email us or call us at this time. I'm going to ask you one more nutrition question. I'm not asking you to say that this is a good diet. I'm asking just for references for folks. The Whole30 diet is a very big fad going on right now. But I do know that a lot of the vegetables that they say to eat and the ones they say to avoid kind of coincide with what you've just said. Would that be a good diet just to look at the foods that are available to eat and not available to eat, just when you think about filling your plate? I mean, of course, adding in, not necessarily avoiding all those foods, but would that be something good when you look at filling your plate to think about?
Well, as a dietitian, we don't recommend any sort of diet,
Of course.
And you'd really want to adopt healthy lifestyle behaviors that are going to be something that you can maintain over the long period of time. So any sort of diet that's kind of recommended for a short period of time is not something that you're going to really maintain. So healthy lifestyle habits are going to be things like eating the more non-starchy, or filling half your plate with the non-starchy vegetables, making those lean protein choices. And so I won't say that some of the recommendations from the Whole30 diet might not be translatable into some healthy habits that you can adopt long term, but I think just looking at adopting things that really you can maintain that are going to improve your health over time rather than sticking with something that's more of a short-term fix is going to be ideal, especially for patients with a chronic disease like diabetes.
Well, and I guess my question, I probably didn't ask it very well. When you look at all the fruits and vegetables that are available, some of the ones that are not available on that diet are stuff that you call starchy vegetables. And so I guess what I was talking about, the filling the healthy part of the plate, the non-starchy vegetables, would it be a good reference to look at those vegetables that they say are approved vegetables and consider making those half of your plate? I think I asked that question really terribly.
Well, I think it can get a little confusing when you try and think about, what's on the Whole30 diet versus what's, on the non-starchy or the starchy list. And so I would be more likely to refer patients to the American Diabetes Association website to see what actually, there are lists, what constitutes as non-starchy versus starchy vegetables. And for example, just because something's not recommended for the Whole30 diet doesn't mean it's off limits. Really, no foods are off limits. You just want to, as I said, make intentional carbohydrate choices and be intentional with your food choices. So definitely some of the foods that are off limits on the Whole30 might be those starchy carbohydrates, starchy vegetables. But I think it's a little easier to manage and maintain if you kind of think about it in terms of starchy versus non-starchy and filling your plate, rather than bringing in this Whole30 diet, which could kind of add even more confusion to the already confusing, navigation of nutrition with diabetes, which can be overwhelming for lots of patients.
Absolutely. Well, I appreciate you bringing in, talking about the American Diabetes website and the list that they have for the food. So that's super helpful. Thank you all so much for joining us, and thank you to our presenters for sharing their knowledge with us. If you will be able to watch this program on the on-demand section of our website, you can go to alabamapublichealth.gov/ALPHTN.